Hi, everybody. This is Maria Durham and a huge team of people in the room welcoming you today to the 2018 Pre-Rulemaking Kickoff. This is the first of a series of meetings as we endeavor to complete our pre-rulemaking cycle, and we're really happy that you have joined us today, and I hope that you find this meeting very beneficial. Next slide, please. So a couple of housekeeping issues, just to let you know, the meeting is moderated. All lines will be muted during the presentation. This is recorded and uploaded to the CMS website for future viewing. So if somebody can't attend and you know that, definitely encourage them to access the presentation on our site. We'll also be accepting questions later in the presentation. Next slide. Okay, so on the agenda, we're going to talk a little bit today about our Meaningful Measures initiative. We're going to talk about pre-rulemaking, the MIPS journal article review, the eCQM readiness overview, the CMS Measures Inventory Tool, the map, lessons learned, any updates, a live demo of JIRA, and then we're going to leave plenty of time at the end for questions and answers. Next slide. Okay, so this is me, and I'm really happy, Maria Durham, really happy to discuss to you today, one of the things that we've been working on at CMS, and it's really our new approach to meaningful outcomes, and we call it our Meaningful Measures initiative. And, with the influx of the health information exchanges, we really have the opportunity to cover many people from birth to the end of life, and we really want them to have a good experience. And I really think we have a common goal, and that's just to have a healthy population. So with this new administration, they really started working on patients over paperwork, which was an initiative that was introduced in October 2017, and it really stresses the agency's commitment towards patient-centered care and improving outcomes while also reducing burden for clinicians and providers. And, this initiative is really about reducing regulatory burden. And as you can probably imagine, we write a lot of regulations at CMS. In my head, it's like 800 gajillion. In reality, it's about 11,000 to 12,000 pages a year, which is a lot of information to digest. And some regulations are good. I mean, they keep us safe, they keep our grandmas safe, but, given the volume of what we do every year, we really have embarked on our own kind of PDSA cycle to see what we can do to improve. And that's really what I wanted to take a pause for today to talk about, because we've set up these agency-wide processes to streamline our regulations and really address burden where we hear the most about. And as you can imagine, quality measures is definitely an area that we hear the most about. So on this slide, as I start talking about our Meaningful Measures initiative, I can say that it's guided by CMS's 4 strategic goals, and those 4 goals are on this slide: improving CMS customer experience, ushering an area of state flexibility, supporting innovative approaches to improve quality, and empowering patients and doctors to make decisions about their health care. And each one of these goals really informs Meaningful Measures. Over the course of my time at CMS, I've definitely had the opportunity to travel a bit, and I've heard some common themes. And, think to yourself whether this is something that you hear about a lot as well. We hear there are too many measures, there are too many disparate measures, and folks don't really understand how these measures work together to tell a measure story that we're really trying to tell. And there's also a huge administrative burden of reporting and a lack of really simplified ways to focus on critical areas that matter most to clinicians and patients, and this is what we're really working to fix. So in our Meaningful Measures, we're really taking a new approach to evaluating what we do, and we're really looking to improve that customer experience so that we can give the kind of care that our patients deserve rather than just having folks meet our requirements. Next slide, please. So as we begin to look at our measures approach, we've talked talked about a number of objectives that we're considering, so that if it means that we're adding measures, taking away measures, if we're looking to fill gaps, we really want to look at specific measures that we're considering against our top-line priorities. We want to be patient-centered. We want outcomes-based, high-impact measures that are relevant. We want to look for areas where there are opportunities for improvement, and we want to address measures that are value-based and, most importantly, aligned. CMS has unique opportunities to continue to guide real measurable improvements, and we're really encouraging the use of more parsimonious measure sets and working to reduce that burden. Next slide. So once we really, with the help of our partners, identified key common quality issues to focus on, CMS introduced a comprehensive approach using a meaningful measures framework to really identify the highest priorities for quality measurement and improvement, and to assess those core issues that are most critical to providing that high quality care and improving individual outcomes. So how does this connect with empowering patients and burden reduction, which is really the key tenets of the patients before paperwork? Well, by reducing the regulatory burdens placed on physicians, we can enable physicians to spend more time focusing on the care of their patients, and this provides patients with more time to focus on their own improved health outcomes. So the picture in the slide shows just that. What meaningful measure areas aim to achieve? High quality health care, meaningful outcomes for patients. You know, here at CMS, we really talk about things that CMS can direct versus things that CMS can enable. And while we're obviously here today to talk about the pre-rulemaking process and things that are very CMS-centric, meaningful measures definitely has a far greater reach, and we've spent a lot of hours kind of talking to our stakeholders, including other payers, to make sure that alignment continues to occur. So, the Meaningful Measures Framework draws on a lot of work by a lot of things that have happened before. Why reinvent the wheel? We've kind of launched this idea at the Healthcare Payment Learning and Action Network. We've worked a lot with our National Quality Forum, who's our consensus-based entity, as well as the National Academies of Medicine. And it also includes perspectives from external stakeholders, such as the Core Quality Measures Collaborative, and some of our federal partners, such as ARC, the ONC, and others. So these works really provided the basis for developing the criteria around measures being meaningful to patients and actionable to providers. Next slide, please. So here's where the rubber really hits the road. And in this single, very tiny fonted slide, this kind of summarizes our approach. And I'd encourage you to really study this in detail. I will definitely be available at the end to answer questions. But I'm going to start by kind of talking through what you're seeing, and then we'll go through a few examples in more detail in the coming slides. So the patient, you can see, is at the center where the patient belongs, along with the 4 CMS strategic goals. Customer experience, state flexibility, supporting innovative approaches, and empowering patients and doctors. And these goals serve kind of as the foundational principles for everything that we do. The CMS strategic goals connect to the 6 cross-cutting criteria: eliminating disparities, tracking to measurable outcomes, safeguarding public health, achieving cost savings, improving access to rural communities, and reducing burden. So these cross-cutting criteria really serve as desired outcomes that CMS, as well as our partners, believed are critical for improving the health system for our nation. So in other words, these are the absolutely most important concepts that we want every priority, every meaningful measure area, and every measure to be filtered through and to be applicable, relevant, and important. So to follow through with that, the 6 quality priority domains and their 19 meaningful measure areas also track to the cross-cutting criteria by working to support the desired outcome. For example, we have a cross-cutting criteria of achieving cost savings. So how are we going to do that? Well, if you look at the quality priority domain on the outside of the circle, and you can see it on the right-hand side as well for making care affordable, this quality priority domain has 3 meaningful measure areas. By focusing on these meaningful measure areas, such as the appropriate use of health care, we can work towards the cross-cutting goal of achieving cost savings and ultimately meet our CMS strategic goals. So each quality priority domain and their respective meaningful measures will guide the reduction of reporting burden for providers while focusing quality improvement efforts really on the most critical areas to better patient outcomes and lower costs. Next slide. Okay, and I'm not going to go through all of the individual quality priority domains, but definitely included this just kind of as a sample. And if you go to our website, you'll see a full description of all of the different meaningful measure areas as well as the 6 quality priority domains. But here's an example, and the title here is Promoting Effective Prevention and Treatment of Chronic Disease. And what you see on this slide is really just a description of what some of our thought processes were when we were really talking about this particular area and what was important. You know, prevention is important. You know, management of chronic disease is important. I mean, many people, 93% of the Medicare population and the spending, you know, it really has to do with people that have multiple chronic conditions. You know, prevention, treatment, and management of mental health. Again, it's a really big area for us and an area where we've got a lot of room to improve. You know, prevention and treatment of opioid and substance use disorders. Again, these are major, major initiatives for this administration, and, you know, they're a real opportunity for us. You know, we're getting better at cardiovascular care. We're getting better at cancer care, but we really haven't figured this one out yet, and it's a national epidemic. You know, we're definitely one of the only first world nations where the life expectancy is actually going down, and in part it's because of the substance abuse and opioid epidemic. So this is definitely something we want to focus on. You know, risk-adjusted mortality also really important, and a reduction of that mortality rate for patients in all healthcare settings. Next slide. Okay. So this slide really shows some examples of measures that come from some of our quality programs that would fit in these meaningful measure areas. The meaningful measure areas are listed on the right-hand, in the middle of the slide, along with examples from our various programs. And this is not all-inclusive. Again, this is just an example, but, you know, what's really important is it's really how we're filtering the information. This is kind of gives us the ability to have a lens across our various programs to really show, you know, what measures we have to address areas that we've identified as important, and it's kind of showing some things. You know, there's some areas where we've got lots and lots and lots of measures. There are areas when we have not so many measures that are definitely opportunities, and definitely some measures that don't belong in any of these meaningful measure areas, and that doesn't necessarily mean that we're going to get rid of them, but it really makes us take a look at why we have them if they're not in one of our priority areas. So we're going through all of our programs right now and really applying this meaningful measure area framework to make sure that we are really focusing where we need to focus. Next slide. So again, this is just really a further breakout to see particular measures that are opioid measures, and you know, this is again really important because it's a national epidemic. And one thing that I will say is that all of these areas are also interrelated. You know, on this slide, you definitely see measures that are specific to substance abuse, but, you know, there are other areas such as interoperability that are also really key to improvement, particularly in this area as well. And it's an opportunity to bring the conversation in with people that we don't generally talk to as much, you know, to make sure that, you know, the infrastructure and the systems are there in order to try to combat opioid abuse. Next slide. So how do meaningful measure areas relate to existing CMS programs? You know, meaningful measures in and of themselves are not really meant to replace existing programs, but they're really meant to help identify measures that are important and the high priority areas that are important. It's meant to reduce burden for clinicians and providers, and it will really allow clinicians and providers to focus on patients and hopefully have a smaller set of measures that we can articulate what our real goals are. We want to prioritize the use of outcome measures through, you know, or high priority process measures, and we want to continue to consider, you know, measures that really move the needle. So what does this mean to specialists? And, you know, taking orthopedic surgeons as an example, you know, we've heard from patients and surgeons that measuring, you know, functional outcomes after surgery is really important to determine if the surgery has been effective in improving or maintaining a patient's quality of life. And that's a main meaningful measure area that we have, and it's something that's applicable across a variety of programs. I mean, a lot of these patients are discharged to home, and we need to make sure that they're able to take care of themselves. So, you know, I hope that every single specialty can see themselves in many of these meaningful measure areas. So how are our current programs going to incorporate this information? Well, a couple of weeks ago, we released the Assessment of Impact report, which is a big triennial report that shows how we're moving the needle in a lot of our quality programs. And all of the key indicator areas of that report directly align with meaningful measures. At the same time, we are in the process of updating our measures blueprint, which is really our Bible for measure development. And we're taking it into consideration in the measures under consideration process, pre-rulemaking process, which is what we're here to talk about today. And we also started doing that last year. And, you know, one of the things that I can report that is really a good thing is that, you know, we get a lot of measures that are submitted through the pre-rulemaking process. And last year we got about 185 measures. And when we applied this framework to those measures, we were able to focus on 32 measures, which is about 16–17% of our original submissions. And this is really what we went forward with. And we got a lot of good feedback that by focusing our efforts, you know, into what is really absolutely important, it allowed everyone else, including all of our stakeholders, to really give us the best feedback possible, and that's really what we're after. Next slide. So I'm sure you're wondering, where do I find out more information about this effort? And we have definitely recently launched a Meaningful Measures website, and that kind of serves as the hub of this information. It includes information such as videos, fact sheets, Q&As, better descriptions of like 19 meaningful measure areas, and it also provides a way to ask questions and provide feedback. And we really encourage you to keep coming back to this. You're welcome to use any of the documents that are on this site and ask us questions, because we continue to want to improve. Next slide, please. Okay, so next steps. The main thing that we're doing, and we really look at 3 dimensions of implementation, and I alluded to this before. We're really conducting, first and foremost, a thorough review of all of our existing measures in our programs and removing ones that don't meet criteria. We'll use the current processes that we do right now to propose measure removal and really identify those high-impact quality areas. And I think you'll see that in the coming years. Secondly, we're in the process of really, in analyzing these measure sets, identifying gaps based off of the meaningful measure framework, and we're focusing any new measures that we're proposing to put in our programs or that we're developing to really fill those gaps and really move towards those higher value measures. And we're definitely focusing our contract dollars as well as our efforts, you know, towards outcome measures and really replacing, you know, some process measures that may not be helping us anymore. Thirdly, we're working a lot to really look at the burden in the area of reporting, and we're using a lot of user-centered design approaches and meeting with frontline clinicians, hospitals, measure developers, EHR vendors to really address the challenges of the high burden of implementing electronic clinical quality measures and collecting data of all kinds. We're working on our API-first strategy and really testing new APIs with vendors, registers, with the goal of being able to simplify the way that quality measure data is submitted to CMS. And this is an area that we're really prioritizing. And, you know, we've got a lot of room to grow, and we're poised and ready to do that. So with continued engagement of frontline clinicians and patients and families and caregivers, you know, we want to continue to drive our efforts towards our meaningful measure framework, and we'll continue to get input, and I definitely would encourage you to give us input. What you see on this slide is the mailbox that is a monitored mailbox where we want your input, and with that, I will definitely turn this over to Kim, who will discuss the specifics of pre-rulemaking.
Thank you, Maria. Next slide. Thank you for that overview of the Meaningful Measures Initiative. As Maria alluded to, you'll definitely be hearing about this more in the presentation as we have made updates to JIRA to reflect the importance of using meaningful measures to identify gaps and prioritize the measures that we choose for the MUC list and more generally measures that we're developing across CMS, et cetera. So I do apologize in advance for some of the repetition, but just as I know it's probably new to many of you, we will give a short meaningful measures overview, like 5–10 minutes, in our subsequent 3 webinars that I will go over later in the presentation for pre-rulemaking, just to make sure that everyone is not only familiar with the Meaningful Measures Initiative, but is really comfortable with the information and can see how the measure they're proposing for the MUC list fits into a meaningful measure area, et cetera. So as we realize that this is new and important for this year. So please be reassured that you'll have plenty of opportunity not only to learn more about this through the website, but to also hear it presented again in a shortened, like I said, 5–10 minute version in the open forums and the Needs and Priorities webinar that's to come. But without further ado, let's start talking more specifically about pre-rulemaking. And if you're new to the pre-rulemaking process, what does that timeline look like? Where does it come from, et cetera? So next slide. So the pre-rulemaking process is statutorily mandated. As listed here, Section 3014 of the Patient Protection and Affordable Care Act. And in the statute is outlined, or the statute outlines 3 major steps, one of which being the publication, the annual publication of the measures under consideration list, and CMS must publish that annually by December 1st. We try our best to publish it a few days early. I think last year was our earliest. And the second important step in that process is then that the National Quality Forum, who's the current consensus-based entity, convenes the multi-stakeholder groups of the Measure Applications Partnership, or the MAP, which we will have a short presentation by NQF later in today's presentation to review. That generally takes place a little bit later in December. And then the MAP provides recommendations and feedback to the Secretary, which is annually published by February 1st. And we'll see later how those 3 steps really turns into a year-long process, even though those dates are only a couple months apart. But we'll walk through that full timeline in a few slides. Next slide, please. So before I get started, I do want to mention a couple of caveats and a couple of reminders, I guess, for this year and for every year of the MUC list. First, measures that are currently in use do not need to go on the measures under consideration list again. There are 2 exceptions to this rule, the first being if the measure is in one program, but it's being proposed for an additional program. Then that measure, even if it's the identical measure, it's being proposed for a new program, so it would go on the MUC list. Or if the measure has gone through substantial changes and now looks different and therefore needs to go back through the MUC list so it can go through all of the great external stakeholder feedback that the MUC list was designed to produce from not only the public, but also the experts on the map and others to make recommendations to the Secretary. Second, as always, if you submitted a measure last year or a prior year and it was not accepted by any CMS programs or not accepted to be put on the MUC list, etc., as always, those measures are eligible and can be submitted for this MUC list cycle as well. And then lastly, we realize that measure specifications may change over time, either from the feedback that you received through this pre-rulemaking process or, again, changes that were, substantial changes that were made during maintenance, et cetera. So we realize that specifications change over time, and so if a measure has significantly changed, it's definitely encouraged and sometimes mandated that those measures be submitted again for consideration. Next slide, please. And so it's very important to state that the pre-rulemaking process that, produces the MUC list and everything that we're discussing here today only applies to these programs. These programs, again, are mandated by ACA 3014, Section 3014 of ACA to go through the pre-rulemaking process. So it's only these programs. So there are obviously lots of other programs that work to measure and report, et cetera, on quality throughout CMS, namely many Medicaid programs. There's marketplace quality initiatives, et cetera, that do not participate in the pre-rulemaking process. So it's good to just be aware of that. And there are more details about those distinctions, et cetera, in the blueprint if you have any interest in learning more about those other processes. And of course, you can always feel free to ask and submit questions. Next slide. So when selecting measures for the measures under consideration list, we look at the measures and ask the following questions. First, does the submission align with quality priorities? And similarly, is the candidate measure fulfilling this year a meaningful measure area gap for this program? And as Maria alluded to, and I'm sure might come up a few more times throughout the presentation, we will, when we look at the trends from year to year, we will see a decline in the number of measures that have gone on the MUC list. And the example Maria gave of last year of approximately 180 being submitted and around 32 being on the MUC list. And a lot of that goes towards us thinking about, or one of the key reasons is us thinking about, does it meet a priority area for the program? Does it fulfill a gap? Third, take a look across the programs to identify potential duplications of measures and making sure, seeing if maybe the newer version is enhanced in some way, could the original measure be removed, et cetera. So that gets to the piece of looking at the various measure submissions and looking at it from an alignment standpoint and seeing if potential alignment can be done and making sure that we're not having undue duplications across our programs, et cetera. Well, the fourth thing that we look at, among others, is making sure that the measure is evidence-based, fully developed, and tested. And part of that testing is, of course, feasibility testing and looking at the burden of operationalizing that measure. And we will have, as Maria mentioned in the overview, we will have a special short presentation around eCQM testing and and highlighting that, as that seems to have been a challenge in past years. And then lastly, we look at the endorsement status. Of course, it's not mandatory that a measure be NQF endorsed prior to going on the MUC list, but it is definitely something that we look at and we consider. Next slide, please. So I talked about the how, so let's go ahead and talk about the timeline. So here's a timeline of what the measure goes through before, during, and after the MUC list. And so you'll see you have the development and testing of a new measure in that initial concept. Again, it needs to be fully specified, fully tested prior to submission on the MUC list. Then, and oftentimes that can take much longer than 3 months, but for the sake of a timeline. So then we have submit measures to the MUC process. Then after several months of collecting those measures, reviewing, we put it through clearance. That brings us to publishing the MUC list, which again CMS does on an annual basis by December 1st of every year. Typically several months, typically later that month, the MAP will have their process to review and make recommendations. Then CMS takes those recommendations and develops proposed rules. And it's worth stating that, that again, the purpose of the pre-rulemaking process and having a MUC list is to garner additional stakeholder feedback from our external stakeholders in addition to the rulemaking process. So it's giving that extra step for CMS and external stakeholders to provide feedback and to consider. And so not every measure that goes on the MUC list has to go into a program. It just gives us a way to get additional, get additional feedback from our stakeholders. So CMS and HHS will develop proposed rules for the measures. They will issue a final rule, and then finally, per comments, if appropriate, the rule will be adopted in the field and made final. Next slide. So I bet you're probably wondering what happens between now, or a little before now, but what happens between JIRA opening and December 1st, because that's a really long time, and I recognize that, to get a measure into JIRA, have it go into what might seem like a black hole for several months, and then December 1st pop back out onto the MUC list. So what happens is that this year we opened JIRA March 1st for new candidate measures. There are two JIRA closing dates. We have one date, which is June 1st. JIRA closes for MIPS quality program measures only. So please be aware, and if you are developing a measure and putting it into multiple programs, please make sure you get it in by June 1st, as that is the date JIRA is closing for the MIPS quality program. And we'll get into it a little bit later about the distinction and why we're calling it the MIPS quality program specifically. The closing date for JIRA for all other programs is June 15th. CMS then takes all of those measures that have been reviewed, takes those measures and creates a draft MUC list that's prepared around the end of July, ideally July 20th. And then we have a federal-only stakeholders meeting to preview the MUC list in very early August. And then by the middle or end of August, around August 20th, the MUC list goes through a CMS HHS-wide clearance process. And we're in that clearance process from August 20th until publication in December, or publication by December 1st. Next slide. So this is a little bit difficult to read, but it kind of makes the point here. As you can see from that extended timeline 2 slides ago, putting together the MUC list is a cyclical, annual, year-long process that takes a while, and therefore there is some overlap between the cycles. And so pretty much at any given point in the year, we are simultaneously simultaneously operating in 2 cycles to make sure that we are not only achieving the goals and milestones that we need to for this cycle that we're currently in, but making sure that we are wrapping up and doing any follow-up and lessons learned from the previous cycle, and then working to prepare the next cycle and making sure that we're incorporating any process improvements, et cetera, for next year. So constantly operating in at least 2 cycles. Next slide. So as Maria stated, we have had this trend down of having fewer measures from our first MUC list compared to our most recent MUC list. Excuse me. And again, that has happened for a couple of reasons. You know, one, as she stated, you know, our hope and our intention is that we're identifying increasingly meaningful measures that really focus and align our efforts and priorities in the programs, and really trying to be very careful about the measures that we pick to reduce burden and make sure that we're getting the most meaningful measures possible for our patients and clinicians. Also, going back to those 5 kind of criteria or 5 questions, 5 or 6 questions that we ask ourselves when we have a measure submitted through JIRA, I think that those have also been refined over the last several years, and we're really making sure that the measures that are produced on the MUC, or the measures that end up being on the MUC list, are fully tested, et cetera, to make sure that we're really giving someone enough information and the measure in the most final state possible when they're providing their feedback, so that we get the best feedback possible from our stakeholders. And you can see at the pre-rulemaking website, which was recently updated and redone. So if you haven't seen it for a while, please go take a look. It is new and improved. You can see a complete repository of all of the lists and reports, et cetera, in one place for the past couple of years. Next slide. So a couple of lessons that we've learned from 2017, like I said, is really the importance of documenting testing status, measure rationale, justification, and evidence. Also, you know, 2 areas where we realize that we can improve on as a whole in our submission, and also perhaps in our communication and making sure that you have adequate information, is the peer review documentation, peer review journal article documentation for MIPS, as well as the test data for candidate eCQMs. And so in just a moment, we will have a quick, or we'll have 2 presentations on each of those topics so that you have the most information possible going into this MUC cycle. Next slide, please. And with that, we have our next steps for 2018. Again, feel free to ask questions. Go to our pre-rulemaking site for more resources, and there'll be a couple of emails at the end where you can email folks questions. But a couple of important dates coming up are our next webinars. These are very typical. We do them every year. We have our open forum discussions, which is really a longer live demo of JIRA. We're going to do a short one today, but then we'll have a longer one Thursday, April 5th and April 12th from 1 to 2 p.m. And then we will also bring together all of our CMS program measure leads and subject matter experts to review the needs and priorities of the various measures. And that will happen next Tuesday, April 10th from 1 to 3 p.m. Next slide. And with that, I will turn it over to Jennifer Harris, who's going to talk a little bit about the MIPS peer review journal requirements.
Thank you, Kim. As Kim said, my name is Jennifer Harris, and I'm going to talk about the MIPS peer review journal requirement. The peer review journal requirement is mandated by the Medicare Access and CHIP Reauthorization Act, MACRA. CMS is required to submit measures to an applicable specialty-appropriate peer-reviewed journal for publication prior to adding new measures in the MIPS program. This submission must include the method for developing and selecting each measure, including clinical information and other data supporting each measure. Next slide, please. This requirement was designed to try to provide clinicians with information on the details of clinical quality measures considered for MIPS, especially those clinicians that are not involved in the MUC-MAP process. Next slide, please. Each measure submission must be accompanied by a complete peer-reviewed journal form. The completed form should be submitted in JIRA as an attachment to the measure submission. We recommend that you copy and paste any duplicative information present in the JIRA submission into the peer review template just to ensure consistency. And here we have the form embedded actually in this slide. If we can click on it, hopefully it will open. I can show you all quickly what this form looks like. This is the information basically that we are asking for in order to meet the MACRA requirement. Examples of a completed form can be found on the CMS Pre-Rulemaking website and in the Call for Measures quality fact sheet. Okay, so as you can see here quickly, there's a few bullet points to address. Some of this information, again, is duplicative from what you will have to enter into JIRA, but to help the review process go smoothly, we recommend that you ensure that the information put in this form is consistent with the information that you put in JIRA so that we don't have to go back and forth trying to clarify which is correct. And again, you can find this form in the Call for Measures quality fact sheet as well as on the Pre-Rulemaking website. Next slide, please. This will be the standardized process for collecting the required information each year, and the form might change slightly, but this template is what we will be using to meet this requirement. So again, here are the links where you can actually find a copy of the form. There are completed examples on the website for eCQM measures as well as non-eCQM measures. Next slide, please. And now I am going to turn it over to Sam Simon from Mathematica Policy Research.
Great. Thanks, Jennifer. So, yes, I'm going to talk a little bit about how CMS determines eCQM readiness and specifically putting a little bit of meat on the bones in terms of how we know that an eCQM could be put into a program. Clearly, before CMS puts eCQMs into their programs, they need evidence that a proposed eCQM can be successfully implemented into a CMS program. And so for eCQMs, there are several pieces of documentation that, when taken together, really tell the story about whether or not an eCQM can be implemented. And we've broken up the documentation into 2 steps that CMS uses to evaluate whether eCQMs can be implemented. So let's go to the next slide, please. So the first step really requires measure developers to provide documentation that an eCQM is feasible, that it's valid, and it's reliable based on testing of that eCQM. And CMS is really looking for testing that happens in at least 2 different sites with different EHRs, but really the preference is for considerably more than that. But at least 2 different sites is seen as the minimum. And this information is really important to help CMS, again, understand if an eCQM can be reported by clinicians or hospitals, and whether or not a consensus-based entity such as NQF could consider the eCQM for potential endorsement. And if you want more information about testing these measures, the CMS Measures Management Blueprint, and there's a link, I believe, on slide 32 of this deck. The blueprint really has a lot of information on testing and is a really good place to start to learn about this if this is all new to you. Going on to the various characteristics, one of the first things that CMS is going to look for is evidence that the measure, the eCQM, is feasible, that it can actually be implemented. And the best way to communicate this information is going right to the National Quality Forum's feasibility scorecard. They have a scorecard that is downloadable from their website. And again, there's a link to that website in this deck. The next major characteristic that CMS needs to understand is whether or not the measure is valid. And really, there's 2 primary approaches to looking at validity for an eCQM. The first one is looking at a correlation between the proposed measure's score and looking at the correlation of that measure with another related benchmark of quality. So, for example, if you are the steward of a measure of diabetes care, you would want to correlate performance with another validated, maybe even NQF endorsed related measure of diabetes. But there's another option as well, if there's not a good benchmark. For eCQMs, it's important to understand that the data that comes out of the EHR and gets fed into the eCQM is valid. So in that case, you would want to do data element testing. And here, the goal is to compare rates of agreement between an extract directly from the EHR with data that are manually abstracted from the full patient record. And so the way we look at this is to look at a statistic called the kappa agreement rate. This is adjusting for chance agreement. But in addition, there are other statistics as well that are helpful to understand the agreement, such as sensitivity and specificity between the EHR extract and that gold standard, the gold standard being the chart abstracted information. In addition to data element validity related to data element validity, if you have an outcome measure and you have risk adjustment for that outcome measure, CMS also benefits from understanding the performance of the risk adjustment model. So being able to provide measures of variance explanation or goodness of fit for the risk adjustment model is going to be really helpful for CMS. And then the last characteristic that's very important to understand is the reliability, which gets at how repeatable or precise a measure score is. And there are 2 primary methods for doing this. One is estimating the signal-to-noise ratio for performance scores among your measured entities. And then the other major approach is estimating an interclass correlation coefficient of performance scores. And typically, you'd want to use a split half approach to accomplish this. Just a couple of words, maybe best practices for testing eCQMs. When you do go and test, it's really going to be important to use or include as many reporting entities as possible and as many different EHR systems, just to give some confidence to the findings that you have. It probably goes without saying, but it's worth mentioning that you should test only using data that matches your proposed data source. So if you have an EHR-based measure, an eCQM, don't use claims data to validate your measure, or at least to validate your eCQM. And then finally, having a summary of the data, a very brief summary of the data and the method you used for testing will help give some context for what you found. So those are that's the first step. And now I'm going to hand off the discussion to Cindy Cullen to talk about some of the technical requirements associated with eCQM testing.
Thanks, Sam. Next slide, please. In addition to solid measure characteristics, the specifications of the eCQMs must align with the standards, form, and manner defined by CMS. There are 3 pieces of the specs that CMS reviews, and each of these pieces is facilitated by the use of tools that are openly available to measure developers. The specifications must comply with the current standards for describing the data elements used in the measure and the relationships between those data elements. These standards include the use of the Quality Data Model, or the QDM, to define the data elements, and Clinical Quality Language, or CQL, to describe the relationships between the data elements. CMS has developed a tool called, conveniently, the Measure Authoring Tool, or MAT, that enables developers to build measures that comply with these standards. The output from the MAT is a zip file that contains several documents that provide the specifications in various formats. This entire zip file should be submitted as part of your measure submission to the MUC list. CMS will review the specifications to ensure that there's alignment between the narrative specification of the measure and the logic expression, and then we'll determine the accuracy and correctness of this logic. All data elements should have valid values associated with them. For example, if a measure includes a particular diagnosis, you need to provide a list of the diagnosis codes that are acceptable. For eCQMs, these valid values are compiled into code lists that are called value sets. To conform to CMS's standards, all value sets must be created and publicly available in the Value Set Authority Center, or VSAC. This tool, sponsored by the National Library of Medicine, provides capabilities to build and store these value sets. Accessing the VSAC requires a free license that can be obtained through the National Library of Medicine. CMS will review the value sets for alignment with standards and, at a high level, the consistency of the codes in the value set with the definition of both the value set and the data element. Finally, to validate the accuracy of the measure's logic, CMS requires developers to create test cases to run against the logic. Test cases consist of sample patients with particular characteristics, diagnoses, encounters, and the like that are created with known expected results. For example, a developer can create a sample patient that would be expected to fall into the denominator of a measure by having a particular diagnosis, but then not meet the numerator conditions. The Bonnie tool can be used to create these test patients and validate the logic. Bonnie uses the MAT output to define the measures. Developers then create test cases right in the tool and immediately validate those test cases against the measure logic. To meet CMS's requirements, developers should test every line of logic in their measures and have a passing rate for these test cases of 100%. Developers should submit their test cases, which you can export from Bonnie, with their MUC list submission. Next slide, please. There's several resources to help you with developing your eCQMs. On this slide, we provide links to the VSAC and the Bonnie tools. The MAT can be accessed at www.emeasuretool.cms.gov. Each of these tools has user guides or training materials available on their websites. The eCQI Resource Center provides links to the standards used for measure development, including both the QDM and CQL. The Measures Management System Blueprint, as Dan mentioned earlier, provides a wealth of information on measure development and includes a crosswalk between the data elements and the accepted vocabulary or terminology standards to be used for each one. Finally, the National Quality Forum provides guidance on measure testing requirements, and the link that we have here is for the feasibility scorecard we discussed earlier. Now I'm going to hand this over to, I believe, Mary.
Great, thank you so much, Cindy. Martin, if you can move ahead, I think 2 slides, actually. There we go, thank you. So today we wanted to do a brief overview of the CMS Measures Inventory Tool. This is a tool that will be new to you for this measure submission cycle. It is an interactive web-based application that was released in fall of last year, and it's really designed to be a user-friendly application to search the CMS Measures Inventory. If you have used the inventory in the past for any of your measure submissions, you're probably familiar with the spreadsheet that was pretty large, contained a lot of data, and you could filter it through the tabs across the top. But really, this web-based tool allows for much easier filtering and searching and provides a lot of the same information, but in much more easily organized and searchable format. Next slide. So the CMS Measures Inventory Tool is designed to include the broad spectrum of measures within the CMS programs. So we do include measures that are currently under development. They'll have the measures that were submitted and approved onto the measures under consideration list going back to 2012. And then it includes measures that had been submitted to the MUC process but were not accepted. Those measures are noted as declined in the system. And then it does also show all of the measures that are in use for a CMS program or initiative. And that can be anywhere from proposed into the program, finalized, implemented, and then even eventually removed. So we do try to provide the historical information for those measures as well. The data is updated 3 times per year, and we align that schedule with this pre-rulemaking schedule as well as the rulemaking schedules for each of the programs. I will caveat that to say, as Maria was mentioning earlier, that they're working with the programs right now to finalize and determine all of the meaningful measure areas for the measures. And so as we get that information, we will be trying to update that as real time as possible. So you may notice some intermittent updates of information, but that would specifically be to the meaningful measure area. We want to get that in there for you to make this submission process as easy as possible. So you might see some updates reflected a little off that 3 times per year timeline. The information that's included for the measures includes a lot of information, but some high-level things that you'll definitely find include the title, description, numerator, denominator, and exclusions. We do include the NQF status and, of course, the NQF ID. We show the healthcare priority and then the meaningful measure area, the measure type, and the data source. Next slide. We wanted to show you this tool today, and we'll do a live demo here in just a second because we think that it will be useful to you in your submissions. Specifically, there's a few fields that request information about whether this measure is used in another program. It asks if there's any similar or competing measures, and then it asks information about whether or not the measure has been published on a previous MUC list before, and if so, to include the MUC year and the MUC ID. So as we were developing this tool behind the scenes, we were trying to keep a lot of these data requests in mind and making sure that all of this information is available to you. So Martin, if you can go ahead to the next slide. The CMIT tool can be found at cmit.cms.gov. And then Martin, if you want to pass the ball over to me, I'll take control and walk through a quick demo. Okay, thank you. Let me just share my screen quickly. Okay. So this is the landing page for CMIT, and as you can see, there's a lot of filtering things across the left side here. So you can filter by program, status, the meaningful measure area, healthcare priority, and so we tried to offer as many options as we thought would be usable for a search. If you've never used the system before and you want some introductory information, you can click the About tab to get to the How It Works. And so they go through a CMIT-specific user guide on how you can use it, but then also some definitions specific to the specifications and the information that's provided for each measure. You can always click on this Measure Inventory link to get back to the landing page. And then this will show you, Maria mentioned at the beginning, there's a lot of measures. So we have a little bit over 2,000 measures to show in this inventory. The measure program results, I'll just show you as an example. This first measure listed here, 3-item care transitions, you can see that it's used within 3 programs. Basically what the measure program results view does is just shows that measure within those 3 programs, but as an individual measure. So sometimes folks are more interested in searching specific to a program, and so this might be a better view to do that, and then you could, of course, filter on, whichever program that you're most interested in to be able to get those measures for that program. But I am going to go ahead and work out of this view first. If there are other columns, this is the default to how you can set your screen to show you the information, but if there's other information that you want to, you can always add columns that you'd want to view. So by clicking the Show Hide columns, you can pick meaningful measure, or if you're most interested in maybe what the descriptions are, by clicking those, you'll see that they are then added across to the right-hand side, and you can filter or you can search to include those columns as well. So just to do a quick walkthrough of what you might need to use this for, let's say you're developing a measure or you're going to be submitting a measure related to cardiovascular. You can search in, type in cardiovascular and hit search, and then based on that keyword, a bunch of measures will show up. And you can see, again, what programs they're used in, what the measure type, those sorts of things. And let's say if you click on this, you'll start to get through the first tab of properties will show you the high-level specifications. You can get some of the developer or steward information on the second tab. Characteristics would be here, again, type, meaningful measure area, the healthcare priority. If it was an NQF endorsed measure, you'd have the ID and the status here. We would also try to list the NQF update date. So if there had been a review or had been under maintenance, you'll get the target population. This is the group identifier. So for those measures that are in QPP, for example, you'll find the group identifier here. It's also associated with the total knee replacement group, so TKR. And then this will show you each of the programs that it's used in, and again, showing the status within those. So the definitions you'll find through the About tab in those definitions. But again, for Medicare PQRS program, that program will be sunsetting, so an upcoming status change for that will show that it's removed with the link showing that it had been removed, that it is currently implemented effective this date. So we tried to put as much information specific to these measures in here for you to be able to easily search across by tab. So then if you come out and you realize that you've searched on cardiovascular and looking through, you actually have maybe a measure you're submitting that's based on statin therapy. So you can then, hone in a little bit more and do a statin therapy search to find any similar measures and to see what programs those might be used in. And so let's say you're looking at statin therapy specifically at discharge. So you might not necessarily have it specific to lower extremity, but if you want to compare some measures, you can click on this box. You'll see statin therapy at discharge. If you scroll down, there's a couple of others. This is an eCQM that's specific to discharge on statin medication. And, another eCQM that's similar title but not quite the same. So once you've selected, you can select up to 3, and then you can actually click on this measure comparison at the top, and it will show you 3 measures that are related to statin therapy at discharge and show you what those descriptions are, the numerators, denominators, to really help you identify whether or not this measure is similar to the measure that you're submitting. And it does go down through a variety of different levels of information, so you can get some of the developer steward information and some of the characteristics specifically around the NQF endorsement status or the meaningful measure areas. And so, you can, again, this provides this measure comparison to see if it really is a similar measure. Okay, and so you can clear all of your filters by clicking out on the X's. Again, you can really do a filterable search. Let's say you're interested in any of the previously considered measures. You can filter by that status. And, if you click on this, and if you're interested in what the MUC information was, you can go back. You can go into the program, and you'll find that the MUC year, it was in 2014, and this was the MUC ID. So again, if that's information that you need to include in your submission, then you'll want this information is all available for you here in this system. Okay, and I think with that, Martin, I'm going to end this live demo, and I'm going to pass the ball back to you. Oh, you already got it. Okay, thanks, Martin. And we can go on to the next slide. I think I'm going to pass it to Erin from NQF.
Great, thank you so much, Mary. If we could go on to slide 39. My name is Erin O'Rourke. I am one of the senior directors at NQF supporting the work of the Measure Applications Partnership, or the MAP. MAP is a public-private partnership that works to promote healthcare improvement priorities. MAP's goals are to inform the selection of performance measures to advance improvement, transparency, and value for all. As Kim was saying, one of the main ways MAP does this is by providing input to HHS during the annual pre-rulemaking process. MAP reviews the measures under consideration for the various federal reporting and value-based purchasing programs, and also identifies gaps for measure development, testing, and endorsement. Finally, MAP encourages measure alignment across the public and private sectors, across settings of care and populations, to help promote care coordination and to reduce the burden of data collection. Next slide. So the value of MAP's input is to facilitate a multi-stakeholder dialogue that includes representatives from HHS. The MAP process allows for consensus building in an open and transparent forum that hopefully means the proposed rules are closer to the mark, if you will, since the main provisions related to performance measurement have already been vetted by the affected stakeholders. Ideally, this will reduce the effort required by individual stakeholders to submit official comments on the proposed rules. Next slide. MAP operates through a 2-tiered structure. There's an overarching coordinating committee that provides cross-cutting guidance and is responsible for finalizing all MAP recommendations to CMS, while the work groups review measures for specific programs, or in the case of the Rural Health Work Group, provide guidance on measurement issues for specific populations. Next slide. MAP members fall into one of 3 categories. Organizational representatives make up the majority of MAP's membership, and they include those who are affected by or interested in the use of measures and are chosen by the organization seated on MAP. The organizational representative aims to represent its entire constituency. Subject matter experts serve as an individual representative that have specific content knowledge to bring to MAP's deliberations. As a procedural note, the co-chairs that lead each work group also fall into this category. And then lastly, we have the federal government liaisons, who are non-voting ex officio members of MAP. Next slide. MAP takes a three-step approach to its review of the measures under consideration. First, NQF staff develop a framework to help organize the measures that are currently used in the program to provide committee members with an understanding of what's currently being assessed. Staff might use something like the priority area or the types of measures to help committee members understand the measures that are currently in the program. Next, MAP evaluates the measures under consideration for what they could add to the program measure set. And then finally, MAP identifies and prioritizes any remaining measurement gaps for the program set as well as across settings. Next slide. The measure selection criteria are a tool that MAP uses to assess the sets of measures used in a quality program. They're intended to assist MAP to identify what an ideal set of measures would be for a public reporting or a value-based purchasing program. They evaluate the program measure set as a whole, which is one of the key things to remember as you look at this slide. The criteria are not meant to be absolute rules. Rather, they're meant to provide general guidance on measure selection decisions and to complement program-specific statutory and regulatory requirements. The measure selection criteria really stress that the central focus should be on the selection of high-quality measures that optimally address healthcare improvement priorities, fill critical measurement gaps in a program, and help to increase alignment across sectors, across settings, across programs. Although competing priorities may often need to be weighed against one another, the measure selection criteria can be used as a reference when evaluating the relative strengths and weaknesses of a program measure set and how the addition of a measure under consideration would contribute to the set. These criteria have evolved over time to reflect the input of a wide variety of stakeholders. And to determine whether a measure should be supported for rulemaking for a specified program, MAP evaluates the measures under consideration against these measure selection criteria. Next slide. So MAP does come to a decision about every measure on the MUC list. The decision categories are standardized to ensure consistency, and each decision is accompanied by one or more statements of rationale that explains why MAP came to its decision. Next slide. So on this slide, you can see the 4 decision categories. They are support for rulemaking, conditional support for rulemaking, refine and resubmit prior to rulemaking, and do not support for rulemaking. MAP may support a measure for rulemaking for a number of reasons. It may address a previously identified gap in a program or help to promote alignment. MAP may conditionally support a measure if it thinks it's mostly ready for rulemaking and they support the measure conceptually, but it needs to meet one or more pre-specified conditions such as NQF endorsement. The refine and resubmit category is a way for MAP to show its support for the concept of a measure, but to stipulate that it needs a larger modification, such as the completion of testing before it should be implemented. And then finally, MAP may not support a measure for rulemaking if it overlaps with existing measures in a program or if a different measure may better address the needs of the program. Next slide. To facilitate MAP's consent calendar voting process, NQF staff conduct a preliminary analysis of each measure under consideration. The preliminary analysis is intended to provide MAP members with a succinct profile of each measure and to serve as a starting point for MAP's discussions. Staff use an algorithm that's derived from the measure selection criteria to evaluate each measure in light of MAP's previous guidance. The preliminary analysis algorithm uses a series of assessments to determine if a measure would receive a recommendation of support for rulemaking, conditional support, refine and resubmit, or do not support. Next slide. So on this slide, you can see the assessments of the preliminary analysis algorithm. NQF staff will review each measure on the published MUC list and determine whether or not a measure meets these assessments. Again, I do want to stress this is not binding, but rather this is the information that we share with the stakeholders on MAP to inform their deliberations on each MUC. Next slide. So on this slide, you can see an overview of our timeline. In the fall, we convened the work groups and the coordinating committee to provide input on the process that MAP will use for the upcoming cycle, as well as to educate stakeholders on the programs that they may review measures for, as well as any applicable updates to the measures that are in the program. Obviously, we prepare for the December 1st release of the MUC list. The publication of the MUC list starts the first public commenting period, where we ask stakeholders to provide any information they may have about the measures or anything they may wish the work groups to know as they prepare to make their initial recommendations. In December, NQF convenes the MAP work groups to make those initial recommendations on the measures under consideration. And then following those meetings, we open a second commenting period to gather feedback on the work group's initial recommendations. Then finally, in January, we convene the coordinating committee to consider both the public comments and the work group's recommendations and finalize MAP's input. We then capture that information and release it in a series of reports from February and March. February 1st, we release a list of every measure under consideration in MAP's decision. By February 15th, we provide MAP's guidance for hospital and post-acute care and long-term care programs. And then finally, by March 15th, we release a report detailing MAP's guidance for clinician programs. Next slide. We do seek new members for MAP on an annual basis. The nomination process occurs each year. About 1/3 of the members have a term that's up for renewal each year. We actually just finished our formal call for nominations. However, we accept nominations year-round. For more information and to apply, you can visit our website listed on the slide. And we are looking for nominations continually from both organizations as well as individual subject matter experts. So I think with that, I can turn it over to Vince for discussion about JIRA.
Hi, thank you, Erin. Yeah, this is Vince Brown. You want to go ahead to the next slide, please? I'll be presenting just a quick overview of JIRA, what's new for 2018. We did have a question come in online asking about the difference between MIPS quality and MIPS cost that we may answer here in a minute, but I can quickly allude to that. MIPS quality is what we used to think of as all of MIPS. This year we had a request to separate the cost measures for certain internal tracking purposes at CMS. The main point is all of these will be counted as MIPS measures. We just needed to be able to separate them by using some variable other than measure type. So there really is no MIPS quality in the measure type choices, if that makes sense. When you enter a new measure, most of you who are in MIPS will choose MIPS quality as your program. My understanding is those who are submitting cost measures kind of know who they are, and they're going down a separate track. But if you're looking for measure type, that's in a different field of JIRA, and you'll see that as we go through the demonstration. The big change for this year, besides the needing to decide whether your MIPS measure is quality or cost, is that in past years we had these priorities or domains, and you could select as many as you wanted, one or more. This year you're required to select one and only one priority area, and then a brand new field for 2018 is the meaningful measure that Maria and Kim and others have described. So you must, within each priority area are certain subsets of meaningful measure areas, and so then when you're submitting your new measure, you'll need to select which one meaningful measure area best matches your measure. The last is a new field for how measures will be reported. We've always asked what is the data source for your measure, but this year we have one brand new field. It is a required field, and it's asking you on the other side, how will the measure be reported? There are just 4 choices, and we'll see that here in a moment when I do the demonstration. If you don't mind, Martin, jump to the next slide, please. So here in a moment, I'll switch over to screen share like Mary did and try to illustrate a few of these new fields. Just wanted to remind everyone, if you're brand new to the pre-rulemaking, the JIRA access is limited access. We ask that you apply, and there's a user guide on the pre-rulemaking website that describes how to do that. We like to the CMS programs like to know who it is that's planning to use JIRA and submit measures. We do offer a blank template offline. That's a downloadable Word file, and we encourage all users to download one of these and create one for each measure. That way you collect all the information offline, and when you log into JIRA, you're ready to go. We had a question a week or so ago about how long does it take to type in a measure, and I looked based on the timestamps in JIRA. We had a user last year who entered 8 measures within a single hour. So that person was ready to go when she logged in, and you know, you can do the math, so it wasn't taking a long time for each measure once you have the information all gathered. One limitation of JIRA, and we get questions about this every year, a limitation that we've not been able to work around is that you need to complete each measure in one session. Unlike some web-based programs, there is no option to stop or pause and save your work and come back later. So once you start creating that measure, you need to work through all the required fields and click Create. If you don't, or if you close your screen, you'll lose the information that you've put in. Most people adapt pretty well to that, but it does catch some folks by surprise, so I wanted to share that. Now, the next question is if I can't come back to that measure and modify it myself, what happens if I have to change it? The answer is, again, in the user guide, it describes a request type called Modify Candidate Measure. So once you've created that measure, it's in JIRA. If you need to make a change, then you create a brand new issue in JIRA that's called a Modify request. And you type in there which measure you're talking about and what kind of change you want to make to it. And then that gets routed through a workflow so that everyone, all the stakeholders who are watching that measure are aware, oh, this one, we have a request to change it. And so that's how that would work. Let's go ahead and switch then to the screen share, if you don't mind, Martin. Okay. Okay, I just put up this login screen so again that everyone would know this is limited access. Once you have your login credentials, JIRA will remember you and you don't have to keep putting your password in, but you do have to log in every time you want to use it. This is what the landing screen looks like. Today, as of today, there are no new measures in JIRA yet for 2018. We have received 2 questions. They show up in the list, so I'm hoping that today's kickoff call will encourage everyone to start putting the new measures in so they can proceed through the CMS review and clearance process. I'll just demonstrate once you're in the project, and JIRA may take you to a different project besides the 2018 MUC list. So you'd come up here to your projects list once you're logged in and search for it. It remembers which projects you have visited before, and so you may have to go to View All Projects to see that. But once you select 2018, it will bring you here to this home screen, and it'll say it right there, 2018 measures under consideration. So if you want to create a new measure, you go to this yellow Create button at the top. And for those of you who've entered measures in past years, this is going to look very similar. Mostly what I want to do today is just highlight the differences from 2017. We will be having, as Kim mentioned, 2 open forums on the next 2 Thursdays where we can get into more of the details for folks who may be new to JIRA and are asked to enter several new measures. We'll also be covering this, again, in greater detail then. So you have various issue types here: measure submission, question, modify candidate measure. It defaults to the measure submission because that's what most people will use it for. I want to scroll down to show you, this is not a new field, but it is a choice in your what is the history or background for including this measure. And Aaron O'Rourke at NQF just mentioned the idea of refine and resubmit. Well, this is a new choice this year. We always had measures that kind of fell into a gray area. Yes, it was on a prior MUC list. It did not get picked up by any program and implemented, but the MAP group said refine and resubmit. So how do I do that? Does it go back through the MUC process? Do we send it around to the MAP group offline? How do we move it forward? So this year you have a choice of identifying that measure in the MUC list as it has been refined and resubmitted per MAP recommendation. That's a new choice for this history field this year. I'll scroll down, show you here. This is the question of priorities, and again, you'll see your same 6 priorities that we've known and used over the years, and so you pick one of those, and then once you have chosen your healthcare priority, and again, as I mentioned before, this is a pick one. You cannot pick more than one priority at this field. Once you choose that, then you drop down here on this next field. What one meaningful measure applies to this measure? These are your choices, subordinate to promote effective communication and coordination of care. So you pick the one meaningful measure that applies best to yours. That way we're sure that each measure has one and only one priority, one and only one meaningful measure. And we go from there. Couple of other points. Again, this came up in a presentation by Mathematica before, but our screen guidance is a little more detailed this year. When I say screen guidance, I will just mention that below each field is a small print paragraph that says what goes into that field. So it's to help you as you're entering measure information to recognize the types of information CMS is looking for. So is the measure an eCQM? That's a yes or no question. If eCQM, enter your MAT number. And then this is a reminder. If this is an eCQM, if that answer is yes, then you must attach your Bonnie test cases, your attestation that it's in the VSAC, and the NQF feasibility scorecard. That's a reminder there, if you're submitting an electronic clinical quality measure, that these attachments have to be there. If you don't attach that material, then someone from CMS or a contractor will loop back with you and say, we need that before this eCQM can move forward. At least that's the way it happened in 2017, and I believe that's the plan for this year. So that's why we changed that screen guidance. I'll scroll back up here a moment and show you, here's our usual question that we've had for years. What data sources are used for this measure? And you can select as many as apply. And there's quite a long list as you scroll through these of data sources. But scrolling down by 2 or 3 more, this is the new question right here in the middle. How is the measure expected to be reported to the program? And again, you can select as many of those as apply. If it's going to be reported in more than one way, you can click it and hold your control key down on your keyboard and select or unselect more as you go. Then you just scroll to the next field and go on your way. That really concludes all the demonstration that I was planning to do, Martin. I think if it's all right with Kim and Maria and everyone, we could switch back to the slide and proceed with questions and answers using the Q&A function on the right-hand side of your WebEx screen. So.
Great. Thanks, Vince. This is Mary. I'm going to take over for the question and answer portion. So we have had a few questions that have come in throughout the presentations today. And so the first question that came in actually goes back to the pre-rulemaking section that, Kim, you were covering. And they asked if the NQF Rural MAP stakeholder group will also be a part of the MAP process.
So this is Maria, and the answer is absolutely yes. You know, that group is critical in really identifying of these measures, you know, what are the most rural relevant, and they are providing that feedback to the MAP.
Okay, thank you. And then a follow-on question was about if there are any anticipated unintended consequences related to removing process measures.
Yeah, so, I mean, again, you know, this is something that we monitor very closely. It's not a one-shot deal. You know, we do a lot of testing, and we try to make sure that we are only considering removal of measures that there's consensus, that there's a good reason to do that, and that, you know, we are doing the right thing. But this is something that we constantly monitor both through our data as well as stakeholder feedback.
Okay, thank you, Maria. And then there was a question, what happens if you miss the time frame for submitting a measure? Do you have to wait until the next year?
So the short answer is yes, you have to wait until next year. Yeah.
Okay. And then if there are duplications or closely aligned measures that are submitted through the process, is there a way to combine them or give priority to one over the other and eliminating one of them? So what happens when you get similar measures?
So when we look at our measures, you know, we're looking at them against the criteria that each one of the programs has provided. So they're really looking at the measure set of proposed measures as a group. So that will kind of come out in that analysis and in that comparison and framework that each individual program is considering.
Okay, great, thank you. And there was a question about how, please send how you submit to JIRA, but hopefully that was answered through Vince's demo. And Vince, I don't know if you want to chime in on how you would actually get an account for JIRA.
There's a link in the slides, in the slide deck to the pre-rulemaking website. And if you go on that website, you'll find a user guide or even a quick start. There are two different documents. We made a two-pager for those who just want to get in and get started, and then there's a user guide that presents more detail. Either of those will describe how you go about getting, you have to get first an ONC JIRA account at the ONC level, and then you send an email to an MMS or Measures Management System support email account, and that's how you get your individual access to enter new measures or to use JIRA for the measures under consideration project. You know, you're welcome to log in and look at measures even if you don't enter any of them. But that would be how you would do that. Through that, the user guide is the best way.
Thanks, Vince. And then there was a question specific to one measure, and it is Quality Insight conducting some sort of quality work on measure number 182, and if so, for what purpose? And I think they might mean QPP number 182, but I'm also not sure if maybe they mean NQF measure 0182. But I don't know if CMS, if you guys have maybe a general recommendation on what they can do for measure-specific questions?
Yeah, so if it's a QPP measure that they're specifically asking about, my suggestion would be for them to go ahead and email the QPP help desk at qpp@cms.hhs.gov. That's qpp@cms.hhs.gov.
Great, thank you. And then the last question that we have that came in online is if there is a plan to add the QCDR measures to CMIT in 2018.
So this is Maria, and you know, we kind of started the CMIT with just the programs that were covered under ACA 3014, which were uniquely Medicare programs, and over time we've expanded it greatly. So as soon as we have finalized measure sets and they're available to us, you know, we do try to schedule them in future releases. So, you know, as soon as the QCDR measures are finalized, you know, we are open to including them in CMIT with the permission of that program, of course.
Okay, thank you, Maria. And I know we are over. Okay, I think that was all the questions we had online, but we are going to go ahead and unmute the lines now for people to be able to to ask questions via phone. So as the lines are being unmuted, we would just ask that if you don't have a question at this time, to go ahead and place yourself on mute so that we can limit the background noise. So Martin, I don't know if you want to go ahead and unmute.
At this time, everyone has been unmuted.
Okay, thanks, Martin. So if anyone has a question they'd like to ask over the phone, you can go ahead and do that now. Okay. In the interim, there was another question that came through online, and I do think that Vince answered it, but I just want to make sure that we acknowledge that we got the question. Specifically, the question was about the CMS cost versus quality measures, and as they were working through CMIT, they were able to find cost resource use measure type, but then couldn't find a quality measure type. And so how would you go about finding and identifying in CMIT what the quality measures for MIPS are?
Yeah, I'll take the first cut at this. This is Vince Brown. I did allude to that in the earlier talk, but I think the short answer is assume that every MIPS measure is a quality measure unless it has a cost resource use as the measure type. In other words, all of MIPS, we chose quality as a label to describe MIPS generically unless it happens to be a cost measure. We needed a way to segregate those from each other. So quality was a label that we developed brand new for 2018 as a subset at the program level that would allow us in the database to distinguish all of MIPS except quality, all of MIPS except cost from those measures that are MIPS cost type measures. So in JIRA, all of the usual measure types are there: process, outcome, patient reported, et cetera, and cost resource use, but there is no quality as a measure type because I think my psychology of it is that quality is considered to be everything that we do is quality. So I hope I didn't confuse things by doing that. And Maria or Kim, if you want to elaborate on the cost and quality distinction, go ahead.
No, I think your initial discussion that assume it's quality unless it's uniquely cost is the right answer.
Okay, great, thanks. And I'll give one more opportunity. If anyone on the line has questions, go ahead with those now. Okay, well, I think that concludes our session for today. Thank you, everyone, for joining. These are your points of contact for any of the pre-rulemaking process. For those on the CMS side, you'll reach out to Helen or Kimberly. You can reach out to Aaron O'Rourke at NQF, and then Vince Brown oversees the pre-rulemaking process as the measures manager, and his information is available there as well. I think that in terms of next slide, I think that's it for our slides. So thank you, everyone, for joining us today. And if you plan to attend any of the open forums, those will be included in the announcements and on the pre-rulemaking website. And again, this webinar was recorded and will be available on that website as well. Thank you so much and enjoy your afternoon.